Okay. Hello, everyone. Welcome to the Year 4C Derm revision lecture for 2025. My name's Keith. Let's just get started. So, in terms of some of the resources I've used, Dermnet obviously has really good photos of our lesions and also has general derm principles when it comes to their management and investigating things. DermSoc has some brilliant resources as well. I got a lot of my information from the revision lectures from last year. Jason did a really good job of being quite comprehensive. I'll do my best to kind of summarize the major points that we need to know. And then obviously ETG's got our specific management. I wouldn't get too hung up about worrying about the nitty gritty about a lot of the management, but general principles are really important. Okay, let's start off with just an overview as to what we'll discuss today, and then look at the anatomy just very briefly again. So when it comes to what you need to know for year 4, on your exam, I would say about 5 to 10 questions are going to be derm related, and then maybe the odd question in the ped section. A lot of the time, these are going to be either buzzwords or spot diagnoses. So you'll read like a couple of words and you'll be like, yeah, I know what that is. Every now and then they might throw in the odd curveball. So something's a bit more vague and you have to look a little bit more deeper into the actual clinical scenario. But a lot of the time you can just kind of elicit what you need to know from the buzzwords themselves. In addition to this, you can really see derm as a potential for your Apex History Pluses. So it's really good to have an idea of how you would go about counseling someone about these rashes, knowing your principles for the management themselves. And then lastly, also, how do we describe our lesions? So there's a lot of terminology that we use when we describe our lesions that's good to be familiar with. You probably won't use them as much for your like apexes, for instance, because a lot of the time you'll be describing things to the patient, and that might be a bit too much. But it's good to know as your framework for when we actually discuss lesions. Great. So skin anatomy, the epidermis, dermis, and the hypodermis. So epidermis obviously is our kind of physical barrier. We've got our keratinized squamous cell epithelium. Generally, if we've got issues in the epidermal layer, these lesions are going to be a bit more scaly and more localized. Whereas with dermis, given that it's a bit more, it's got like connective tissue, neurovasculature, and so on. Issues in this area are going to produce kind of more swelling and edema. And then obviously our hypodermis has subcut tissue. Right, Fitzpatrick scale, something good to know from 1 to 6. Good when we're describing our risk factors, especially for our benign and malignant conditions. And then our general derm principles when it comes to the management. So always start off with your lifestyle. There's going to be things like your SNAP-W and kind of addressing risk factors, triggers for certain rashes, and what are the things we can do from a non-pharmacological standpoint. There's a lot of potential when it comes to derm things. And then obviously when we start off with our pharm, the first line is often going to be topicals. We've got creams and we've got ointments. Ointments, you might have heard, are a little bit more oily, but they're a bit harder to actually like apply. So it could be up to patient preference if both options are there. But given that ointments are a little bit more effective, a lot of the time we try to favor them, but creams are perfectly fine as well. UV therapy where it's appropriate, depending on the condition, and then systemics, so our oral immunosuppressives and non-immunosuppressives. And then we've got some biologics that we can also consider as well, depending on what we're discussing. Chemo, radio as well for our malignant and benign lesions. Okay, so starting off with our terminology, I like to think of things as, is my lesion, first of all, like flat, or is it raised? If it's flat, we can either call it a macule, so it's more than 1 centimeter, or a patch where it's greater. If it's raised, then we can think about, is this like a fluid-filled lesion itself, or is it kind of like fleshy? So in the case of it being a fleshy lesion, we can call it either a papule or a nodule based on size. If you can pinch it between your finger and your thumb, then it's going to be a nodule. Okay, plaques are where our lesion itself is flat-topped. And then um, for our fluid-filled lesions, if it's just less than 0.5 centimeters, it will be vesicles. Um, if it's greater than that, we'll be considering to be bullae instead. Then we've also got pustules, where the collection is filled with pus, as you would imagine. There's also something called wheals, which is where the fluids are leaking from blood vessels and we get localized dermal edema. That's going to be like your urticaria hives. Okay, that's just a bit of a summary as to what we've kind of discussed. And then some additional things to keep in mind, especially for our malignancies, are going to be this ABCDE kind of framework. So is the lesion itself asymmetrical? Are the borders well defined? Is the color kind of very homogeneous, or is there kind of changes in the color? The dimensions, obviously depth is a little bit harder to assess, but the diameter is something we can observe. And then the evolution. So comparing it to previous, how has it changed? Is it slow growing, rapid growing, that side of things? Okay, and then these are just some kind of flowcharts describing how we can think about scaly erythematous rashes. I think these are from the GP Derm tutes from faculty. So you can have that framework as well when it comes to deciding, is this rash also itchy? Is it acute, chronic, and is it fluctuating during that period? Great. Onto the actual matrix conditions themselves. So as you can see, there's a lot of R1 when it comes to dermatology, and a lot of these have subsets within them, like all these infections, the melanomas, and it can be a lot. So when it comes to learning your derm conditions, I think a big part of it is like, how do I recognize it? How do I need to investigate it? And how do I generally manage it? You don't need to currently know all the specifics, but it is good to know certain things like strength of your steroid creams. Also, when it comes to, say, surgical margins, we need to know that for when we're excising our lesions, how big of a margin we need. And we'll talk about that when we get to the relevant conditions themselves. Great. So let's start off with our inflammatory skin conditions. Just to start off with what dermatitis is. Just dermatitis is inflammation that's going to involve our epidermal layer. We can split that itself into two subcategories. We've got endogenous, which is where it's kind of not an exposure to something, but rather from our own body itself. And then exogenous is in response to something else. So endogenous are two main ones that we care about for our for your exams are going to be atopic dermatitis, that's eczema, or seborrhoeic dermatitis. So that's realistically kind of like dandruff is a mild version of that, or cradle cap, which is something we see in our peds patients. And then for our exogenous, these are going to be contact dermatitis. So again, it's in response to something, and we can split that into allergic or irritant itself. Okay, so let's start off with eczema, which is very, very common. We get scaly red rashes, which are very, very itchy. And what we get as a result of an actual kind of trigger is immune cells move to the epidermal layer, they degranulate, they cause inflammation there. So in kids, it's about 15 to 20%, whereas as we get to adulthood, only 2 to 10% really have it, but still pretty significant. And we have triggers for them. Now, again, it's like slightly different to how allergic contact dermatitis is like we've applied something and then we have a delayed reaction. We'll talk about that. Whereas eczema is just like things that are like irritating in a sense. So scratch is the mnemonic we can use for that. Soaps, chemicals, anything rough, so sand, allergens and animals, terrible infections, a bit of a stretch when it comes to the mnemonic, clothing, heat, and then other things like stress or bathing. Generally, there's a lot of different things that can trigger it, cause it to flare up in a sense. Whereas we'll talk about allergic contact dermatitis in a little bit. Okay, I didn't skip anything. Great. In terms of the presentation itself, 10 out of 10 itchy, red, scaly rash. It fluctuates, and when we see this rash, it's not really well defined. In terms of the distribution, The ones that we often care about are going to be flexural, so we're going to be thinking about our QB or popliteal fosses. Also in the neck, the wrists, ankles. Whereas in infants, it can be a bit more like facial or in the extensor surfaces. And then we might keep an eye out for secondary infections because there's a compromise in our epidermal layer, and that makes us prone to kind of having those superficial infections. So impetigo or HSV, which we'll talk about. Most cases will improve with age, but it can persist, and we may need to kind of consider occupational stuff. So if they're, say, a hairdresser and they're constantly exposed to stuff and that's flaring up their eczema, we might want to consider certain things. It's a clinical diagnosis, but we can do allergen testing if we want to be a bit more kind of specific, looking for if they have this kind of underlying atopy and stuff like that. If they've got like impetigo, we can consider a skin swab, but generally don't really need that. And then in terms of how we manage it, so non-pharmacologically, A, B, C, D, E. So we want to avoid our triggers, soaps, irritants, overheating, whatever it is. Then bathing, we want to have short, lukewarm showers, and we want to avoid hot water and soaps. We want to avoid bathing and just sitting in the same water as well. Making sure our clothing's non-irritating, loose as well, avoiding certain materials like wool, synthetic fibers, and then damage prevention. This is especially important for our like peds patients. So moisturizers are good for everyone. Do it like 2 times a day, but then also cutting nails so that you're not kind of reflexively scratching yourself and re-irritating the areas. And then E for education about the condition, corticosteroid therapies, which is what we do from a pharmacological standpoint. We can also consider some other things. So oatmeal baths are something we can consider if they're very itchy. And then if they're having flares, we can do bleach baths. We might do that every day with the flare itself to reduce kind of the bacteria in the area. We might also do wet dressings to help with the flares themselves. And it can help with actually the topicals we use. All right. In terms of what topicals we want to use, first of all, again, ointments are better, but they're just a little bit harder to apply than creams. And we've also got lotions, which are liquid form. We want to do it once daily until the rash is completely gone. The reason why is that if we're undertreating the inflammation and we just stop early, the recurrence is going to be more common. We need to make sure that we fully actually treat it until it's gone. Depending on where it is, the actual steroid you use changes. So face, we use a weaker steroid, whereas if it's on the limbs or the trunk, we might use something stronger like triamcinolone acetonide. 0.02%. Some of the adverse effects that are important to keep in mind, I think the main ones that I would know are like hair thinning and then the steroid-induced dermatitis. These are things that are good to tell your patients about that, you know, when we actually start you on these are some of the things to keep in mind. So your hair might be a bit thinner in the areas that we're applying these, and it can also itself cause dermatitis. But worth noting that, you know, some people might be a bit apprehensive with starting a steroid, but systemically it's not that concerning. Other things we can consider if we feel like we don't want to use steroids or we want to do something a bit stronger. So calcineurin inhibitors are an alternative, pimecrolimus. We might use that for those sensitive areas themselves. And then our systemics. So oral pred, we can consider for short use, especially in our flares. And then we've got some immunosuppressants, biologics, and JAK inhibitors. But by that point, you're probably going to be getting some derm input as to what you should go with. From an itch standpoint, sort of depends what you want to use, but it's actually recommended that we can use a sedating antihistamine, especially at night, so promethazine. That's particularly because when you get that itch at night, it's particularly annoying. And so if we give a sedating antihistamine at that time, it also will help you to sleep. Great. Just stole this from RCH, TBH, but this is how we can think about our framework when it comes to actually counseling our patients. So giving them follow-up within a week or 2 weeks is generally good to kind of keep an eye on how their actual rashes are improving or not, making sure that they're doing the moisturizers with the topical steroids themselves, um, wet dressings, things like that to help with the absorption as well. Great. And then some of the complications. So psychologically, patients might be a bit concerned with the rashes themselves. So it's good to counsel them with this and reassure them that with the cream themselves, these lesions, these rashes should improve. Again, steroids and biologics have their side effects. The systemics have that immunosuppression, so they might be a bit more susceptible to infections. And then impetigo is where the eczema gets infected itself. We might see crusting similar to this image up here. Depending on how severe it is, we manage it pretty much as impetigo. And if it's really resistant, we might consider swapping it and doing some stronger antibiotics. Eczema hepaticum is where it might be a bit hard to appreciate on the image here, but these lesions are a bit more vesicular. And so we've got a HSV infection there. This is an emergency. This patient needs to potentially go to hospital and get some oral antivirals. So acyclovir is what we'd use. Okay. Seborrhoeic dermatitis, or colloquially kind of dandruff, is the mild version of it. We've got areas with lots of sebaceous glands, and the skin basically responds to a Malassezia furfur, which is normal yeast flora on our skin, but the body just kind of reacts to it in certain cases. As a result, we get inflamed erythematous skin, and on top of that, we get this scaling. Generally, it can be like yellowy or white, flaky skin stuff. Cradle cap, we can see in the first few weeks of life. It's very well defined, and the main thing is that it's self-limiting. It's going to resolve on its own within, say, like a year. As for our adults, we pretty much manage it very similarly to eczema. The main thing that we can consider on top of that is topical antifungal, so ketoconazole. That's something that we can use, or cycloperox. I haven't practiced saying these medications. Depending on how resistant it is, we can go to some stronger stuff, but it's up to how they respond, I guess. Keratolytics, we can also consider to remove their scales as well, but we'd also be like doing our wet dressings and stuff like that to help remove the scales and improve our application of our topicals. But yeah, for our cradle cap in our peds patients, we don't really need to do topical steroids. We can just kind of moisturize, fine comb to remove the scales and go from there. Okay, these are some other endogenous dermatitis variants to just keep an eye out for. Not super high yield, but discoid, you get these kind of circular rings. Pomphilox is dihydrotic. Again, we need potent topical steroids. Varicose is something that we can see pretty commonly. So we've got venous insufficiency. As a result, we get kind of the areas affected in your lower limbs. And then astiotic, which is seasonal and will respond well to your topicals. Okay, irritant contact dermatitis. So now we're moving away from the endogenous dermatitis and we're going to exogenous. So irritant is where we've been exposed to something, and as a result of its direct toxic effect, we get dermatitis. So it's nothing to do with immune side of things, nothing to do with atopy. It's just going to be a response to an exposure. Depending on the case, it could be a chronic thing. So they're getting repeated exposures to something that's toxic to the skin, or it could be an acute high-grade thing. Yeah. We're thinking about occupational stuff as well. So our cleaners, our hairdressers, food handlers, they're the people that could be at risk. Triggers can be various. So you can think about chemicals, or it can also be physical as well. So friction, or heat or cold, depending on the burn. Yeah. But we get very well demarcated red rashes. And then the surface over that is going to be a bit glazed. Rapid onset, well, it sort of depends. It could be either very rapid or because it's chronic, it's built up over time. But yeah, if it's a strong irritant, it can be very painful. There could be swelling. We could see vesicles bullae around. Whereas if it's mild, it could just be a bit dry, a bit thickened. In terms of how we manage it, we want to avoid the irritant using PPE. One thing to note is that we can change the irritating agents, but they don't have to say like swap jobs or anything like that, because it's just because they've been like splashed by something that it's directly like toxic. And that would happen to kind of like anyone. Topical steroids can be used as well, emollients, antibiotics if they're infected, and we go from there. Allergic contact dermatitis, on the other hand, I remember I had a real tough time differentiating allergic contact from atypic. But allergic contact pathophase is different. We get a type 4 hypersensitive reaction where it's a delayed presentation from an exposure and it will persist ongoingly. So our triggers, there's a lot of random ones, but nickel, so things in like jewelry, for instance, is very common. Rubber, also like acrylate in like nail cosmetics. And then also in like elderly patients, some topical antibiotics can cause this. Now, clinically speaking, it arises after a few hours with the exposure, but it can take a few days to fully actually resolve, even when you're not exposed to this allergen itself. So we get erythema, an itch. There could be papules and vesicles in the area itself, blistering, pustules, whatever. The diagnosis is we can do an allergen patch test to look at what the skin is specifically reactive to. And again, with the management, in these cases, these patients need to consider a potential job switch to a different thing, because every time they go to do this job, they're going to have this happen. Again, different to irritant, where it's like kind of everyone will get that. So PPE is the better option because we need to just make a barrier from actually being exposed to that. And then again, emollients, topical steroids, and then again, we can consider calcineurin inhibitors if steroids aren't necessarily as appropriate. Okay, next. All right, psoriasis now. This is a chronic inflammatory process. We get well-demarcated silvery plaques. So if you see like salmon, oh, we'll actually talk about that in a bit, never mind. These plaques are generally not itchy, they're just sort of there. It can, from an epidemiology side of things, common in young adults and common in like middle-aged 50 to 60-year-olds. 10%, only 10% have psoriatic arthritis. So even though they're similarly named and they are a little associated, you don't need psoriasis to have psoriatic arthritis, and you don't need psoriatic arthritis to have psoriasis. I think I said that right. A big thing to keep in mind with psoriasis is that they are 2 to 3 times more likely to have cardiovascular disease. So if you see psoriasis in like a history plus, good to keep in the back of your mind about, hey, do they have cardiovascular risk factors? Should I be concerned about that? Other risk factors for psoriasis, smoking, alcohol, and obesity are big ones. Depending on certain infections, so if they have a group A strep, they could get guttate psoriasis. Emotional stress and trauma can also flare these things. And certain medications as well can cause these to rise up. Yep, cool. Histology-wise, the actual plaques themselves are the keratinocytes. They are hyper-proliferating, so they grow very fast. We get vasculature that proliferates as well. That's why it's red, and inflammation in the epidermis itself. The buzzword is salmon pink or silvery plaques over your extensor surfaces. So pretty much if you see it over their like shins or their forearms, and it's silvery and it's a plaque, it's probably psoriasis. Other things to keep in mind is that it's well demarcated, and then there can be nail changes. So pitting, onycholysis, which is where the nail bed kind of lifts off, ridging, keratosis, easy to break, and discoloration. But yeah, just keep in mind that nail changes happen in about 50% of these psoriasis patients. We've also got the Koebner phenomenon. So someone goes to get a tattoo, and then after which they get the redness that forms and new lesions, new plaques are going to form on top of that. The Auspitz sign as well is where underneath the lesion itself, we get pinpoint hemorrhages. That's another thing you keep in mind. Some of the variants with psoriasis, I wouldn't get too hung up on this. So guttate is associated with group A strep infections, self-resolving. Pustular, we get inflamed skin, and then that's going to spread. If it's localized, it's okay, but generalized, where they might also have some systemic symptoms of fever and malaise, they need to go to hospital. It's an emergency. Erythematous, we might see some temperature dysregulation. The electrolytes might be a bit funky, but it's affecting a massive area, whereas our normal psoriasis is just kind of in plaques, so smaller lesions. This is also an emergency. You can also see psoriasis in the flexural or skin folds, and then palmoplantar as well. These lesions can have like pustules as well. How do we manage psoriasis? So we can keep in mind the kind of ABCDE framework generally as well. It's going to be a lot of those like avoiding triggers. So things like tattoos or stress, we might address those as well. SNAP-W is also really important because smoking is a big risk factor, as is obesity, as is alcohol. Moisturizers and then gentle sun exposure is really going to be important for our management. The reason being is that for our topicals, we do use potent steroids, so for about 6 weeks at most, intermittently to help break down what's going on. And then we also use calcipotriol, which is like a vitamin D analog. This is good for our like long-term use, so ongoingly to help with the actual plaque formation and breaking that down. And gentle sun exposure is going to help with the actual absorption there. We can also consider some other agents, so tar and salicylic acid. I know tar sounds ridiculous. I remember hearing about that and I was like, that sounds absurd. But we can consider that because it's an anti-inflammatory and works for the itch as well, if there is one. Again, psoriasis is not really itchy, but can be. Narrowband UVB specifically can be considered. And then some systemics, so methotrexate, acitretin, which is a vitamin A analog. But again, when we're getting to that systemic level, we might be considering some derm input to help us out. Okay, urticaria or hives. So we get wheals, which I mentioned are like these itchy and swollen lesions. They're going to be very red. They come and then they leave very fast. And they're going to be blanching as well. Again, they start very fast. They don't really last for more than a day and then go away. In terms of causes, it can be a bit hard to actually identify. Half the time we don't really know, but certain things like infections, drugs, foods, exposures to certain things that can cause basically an allergic reaction in a sense. Main things to keep in mind are, again, wheals, it's a short duration. It can be migrating as well. Some other things that are interesting, dermatographia, which is where you can actually scratch on the skin area and then that causes the area to raise. It's kind of interesting. We can use the Urticaria activity score to monitor the progress, especially if it's chronic and reoccurring, to just see how it's going. And then from a lifestyle standpoint, avoiding our triggers, if the itch is really bad, we can consider some oat milk baths. And then we often will go with a non-sedating antihistamine, so loratadine, fexofenadine. If it's a bit more severe, we could consider a short pred course or some systemics like montelukast. All right, benign and malignant tumors. Tumors or lesions. There's a lot to unpack here. We're going to be starting off with kind of the spectrum of SCC, squamous cell carcinoma, and then we'll do BCC, and then we'll go into melanoma after. So, actinic keratoses, AKs. These are going to be dysplasias of the keratinocyte, so that top layer, but only kind of like partially. So they're not that bad. It's a result from sun and UV exposure, and these lesions don't have that high of a kind of malignancy transformation, but Their presence can indicate that they could be high at risk of cancer in the future with other lesions. In terms of what to look for, scaly lesions, the areas are going to be sun exposed. The color can vary, but we're looking for like crusting, rough. You can see that the base underneath here is a bit red. And ultimately, these sort of keratoses can resolve on their own. So realistically, when we do our management, it can be a lot of preventative, primarily because we know that this could indicate that they could have a high risk cancer in the future. So sun protection, making sure that they've got sunscreen and shading, that side of things. If these lesions are particularly bothersome, we can consider like some nitrogen, liquid nitrogen to do our cryotherapy on them, or we can go with some topicals. So 5-fluorouracil cream, imiquimod, diclofenac 3%, if you're feeling like you want to do that. I haven't got a photo of it as well, but we've also got these like cutaneous horns, which is where these actinic keratoses just like build up. And if we want to get rid of them, we can consider a shave excision or curettage, which is where we just take layers off to kind of whittle it down. Okay, next is Bowen's or SCC in situ. Basically, because our SCC is affecting our epidermis only, SCC in situ doesn't penetrate the basal membrane. So it's a full thickness intradermal carcinoma. About 5% of these will progress into SCC. And when we look at the lesion itself, it'll look very similar to our SCC themselves. Could be a bit uncomfortable to palpate. And the risk factors for this are similar to AKs, but we may also see like HPV infection can be associated. Again, to manage these, I would say that cryotherapy is the most common one, but we can also consider topical like 5-fluorouracil, photodynamic therapy as well as an option, and we can potentially surgically excise them depending on the location, so using a curettage or a Mohs. Okay, SCC itself, squamous cell carcinoma. We get our keratinocytes, they're malignantly proliferating, and they've invaded into the dermis now. So we see this quite often in our immunocompromised patients. Some of the risk factors that we need to keep in mind are the UV exposure, smoking, occurs more in men than women. If they're older than 50, fairer skin, that side of things. What to look for? These lesions are going to be raised. Oh, that's such a low res photo. Sorry. These lesions are going to be a bit raised, scaling, and the sites are going to be sun exposed. They can be inflamed potentially. They can hemorrhage as well. They're going to be chronic and poorly defined. The areas that are most affected are going to be on the head, the neck, and then you could see it on the limbs or the trunk as well. When we see these lesions, almost always are we really going to just take it out. So with 5 to 10 millimeter margin. But if it's a small or low risk, we could consider doing an aggressive cryotherapy instead. But generally speaking, we're going to be excising these with a 5 to 10 millimeter margin. We've also got keratoacanthomas. I think the main thing to just know here is that they've got this volcanic appearance. So they're raised like this as a papule, but then in the middle itself, we've got a central keratotic plug. So this exact image you could see on your exam and you'll be like, yep, that's a keratoacanthoma, move on. They can spontaneously resolve, but generally we just try to take them out. Okay, let's move on to BCC. So we're looking at the basal cells, not the actual keratinocytes now, which was SCC. The stratum basalis. This is the most common skin cancer, actually. Similar risk factors to SCC, including this Gorlin syndrome. And the buzzwords that you really need to know are going to be that this is a nodule that's pink, pearly, so it could be translucent, and then rolled edges is just what you'll see for BCC. They don't generally met, and 80% of them are going to be kind of nodular in in form. Some of the different types that do exist. So rodent ulcer is just what happens when the ulceration actually occurs. We get central depression. The edges around it are going to be rolled and non-tender, and this doesn't heal. We've also got superficial multicentric. So it's going to be shiny and pearly, a plaque, so it's still technically raised. Infiltrating is a bit harder to tell. Like I was looking at this image and I was like, I think it's that. But the borders can be a little bit indistinct. Micronodular is where the borders are very poorly defined and they rarely ulcerate, even though this one low-key kind of looks like it did. And then your BCC can also be pigmented, but again, noting how we've got this like kind of pearly or translucent kind of image there. In terms of how we manage these, so from a lifestyle side of things, SNAP W again, sun protection, regular skin checks to look for other lesions as well. And then pharmacologically, we can either go with imiquimod or 5-fluorouracil. Surgically, we can also consider an excision with a 3 to 5 millimeter margin, so a little bit less. We can, if it's a superficial, do a shave or curettage instead. And then if it's cosmetically sensitive, again, the Mohs is something that we can consider there. If it's a smaller or low-risk tumor, again, we could consider an aggressive cryotherapy, but they generally, we might just excise it or just pharmacologically do our chemo. All right, melanoma. Melanoma is a big-ish area. We're looking at the melanocytes and them being malignant now. It's only 5% of all skin cancers, but 70% of all candidates. So something that we have to take really seriously. When it comes to our risk factors, UV exposure, as we'd expect, any family or past history or previous skin cancers. If they've got melanocytic naevi, Fitzpatrick 1 or 2, and then certain genetic things as well. Now, important to note that these can occur anywhere. So even though UV exposure is a thing, these can occur anywhere, not just in the sun-exposed areas. When we go about evaluating these, we want to know how has this lesion changed? Do they have risk factors? Have they had previous surgery? Is there any history in the family about melanoma or nevi? Then we want to do a full top to toe skin exam, looking at their lymph nodes as well, and then looking under a dermatoscope specifically at the lesions themselves to determine is this concerning or not. Again, ABCDE is how we can do our framework for identifying, is this something that's just a melanocytic nevi, or is this something that we need to be a little bit more concerned about? Some of the subtypes we've got. Superficial spreading is by far the most common. See it on the upper back, the upper arm, and the lower limbs. A lot of these are from pre-existing melanocytic nevi, but the good news is that they metastasized late, so there's good prognosis with that. Lentigo malignant melanoma. If it's in situ, it's just lentigo maligna, whereas if it invades, then it's actually the melanoma itself. Chronic exposure to sun, and again, these have a relatively slow transformation into malignancy themselves. Now, nodular, in 15% of our cases, is where the lesion itself is elevated and rapidly growing. So these are going to be more aggressive. It's a bit harder to follow the ABCDE assessment of it, but these are really concerning. And then we've got acral lentiginous. I think that's how you say it. Lentiginous? Anyway, the areas that these affect are going to be like your palms, on the nails themselves, which is subungual, and then on the soles of your feet as well. So a bit atypical. But these are also not as concerning as, say, nodular is. There's also desmoplastic, which is a bit rare to see. Okay, when it comes to our melanoma, the main thing that we use to classify, or not the main thing, but one of the main things, is the Breslow thickness. So this helps us stage how severe this melanoma is. Starting off with, if it's still in situ, there's a really good prognosis of 90 to 100% survival. If it's invaded and it's still less than 1 millimeter, then we're at stage 1 Breslow. And as we get more and more thick, 1 to 2, 2.1 to 4, and then more than 4, you can see that the 5-year survival rate really drops off. So we want to get this as early as we can, identify and excise it quickly. So investigation-wise, doing a full skin exam, because again, melanoma can appear anywhere. We want to be sure that we're not missing anything. Once we've found lesions that are concerning, we're going to be doing, first off, an excisional biopsy. So at the area of interest, we're going to be doing a 2 mm margin, and we take it out with local anesthetic, obviously. Take out the whole lesion if we can. If it's in certain high-risk areas or the lesion's large, we could do an incisional biopsy, whatever. And then also, if the thickness, once we've identified it, is greater than 1, so going back here, if it's stage 2 or higher, then we can consider doing a sentinel node biopsy. We want to check that this hasn't spread. Imaging-wise, can consider a full kind of CT or PET scan. Excuse me. And then management-wise, so for all of our patients, we want to make sure we're actively surveilling them because we want to make sure that there's no other melanomas appearing. And then for the actual melanoma itself, we're going to be doing a wide local excision. So going back to that same site, and depending on the thickness that we've got, we're going to be doing a different margin. So if it's still in situ, we do a 0.5 centimeter margin. If it's less than 1 mm thick, then we can do it with a margin of 1 centimeter. If it's 1 to 4, then we're going to be doing a 1 to 2 centimeter margin. And then if it's greater than 4, we need to do a very significant margin, so 2 to 3 centimeters. Again, with other options, sentinel lymph node removal, we can really consider, but it's only good for a prognostic side of things, not really like symptom-wise in a sense. Then for our regional mets, again, we would take out the lymph node that it's metastasized to. And then for our chemo, there's a few different options there as well. But generally speaking, we want to go with our wide local first, unless there's significant mets where we may need to consider chemo. All right, melanocytic nevi, or moles, are where the melanocytes are proliferating in a local area. And we can stratify them into non-familial or familial, which is basically, is there a family history or not? If they are non-familial, and when we do our assessment with ABCD, we find that that's atypical, there's something off there, it's got a 2 to 8% risk of actually being something concerning. So we want to do photography and dermatoscope to actually look at this lesion and observe it, monitor it. If we've got melanoma in one or more relatives, then these patients can have a lot of moles. The histology themselves will be atypical, and there's a 100% lifetime risk of melanoma. So we are very worried about these patients. Now, for the macroscopic appearance, it kind of depends where this cluster is. If we look at this page, if it's more superficial, you can kind of imagine the melanocytes are higher up, so they're a bit more visible. So the actual color that we see is a lot more darker. If it's between the epidermis and the dermis itself, then you can see that it starts to become a bit more skin colored. And then once it's full in the dermis, it's really not visible at all. 1/3 of our moles evolve into melanomas. So that's why we're really worried about these. Okay. And then I think I just had a quick point about melasma. I'm not going to spend too long on this, but this is just where sun-exposed areas can become hyperpigmented. So there's a color change, but there's no real like papule itself or nodule. These are not to be worried about necessarily. It can often be in response to hormones, medications, UV exposure as well. When we're managing this, we want sun protection. We can consider some topicals depending on what we need as well. And then some of the other pigmented lesions to look out for. So lentigo is where we get these macules or patches. And we don't get the nesting of the melanocytes, but there's just an increased number of them in those areas. SebKs, these are very common. They're harmless, often just in our older patients, and they've got this kind of smooth, waxy surface to them, so not to be too worried about. Atypical nevi, so you can see how this is like got changes in the color itself. The border is not gray, whereas if we compare it to this, there's a very nice border here, and the color itself is pretty consistent throughout. So these are a bit more suspicious, but again, you don't really know until you actually go and biopsy it to look at the melanocytes themselves. And then a couple of red lesions that we've got. Campbell de Morgan spots or cherry angiomas are where we get a vascular lesion. The endothelium itself is proliferating. These are going to be a bit slow growing and persistent, so they always stick around. Whereas we can also get pyogenic granulomas, which are also benign with the capillaries growing. But these are really rapidly growing and they can kind of be broken down if you press on them as well, and they'll bleed if you do. All right, let's go to pilosebaceous conditions. Well, before we do that, I need a drink of water. Okay, so to start off with, acne. Acne is obviously very, very common. You see it with everyone. The pilosebaceous unit itself is like a hair follicle, and then the sebaceous lobule is what secretes like our oils. When that is obstructed, we get inflammation in the area. That's what creates our acne. Depending on the actual kind of issue going on, we can either get closed or open comedones. Then we can get inflammation, and then if it's more severe, we'll get nodules. Very, very common. Pretty much everyone would have had it at some point, but it will go away as you get older, more often than not. And again, a few different things going on here. There's this Corynebacterium acnes that colonizes the area, but don't need to know that for your exams. Okay, clinically, we can have mild, moderate, or severe, depending on what's going on. So at the mild stage, we get comedones, and that's basically, if I go back here, it's before the inflammation actually occurs. So there's like obstruction, but there's still no inflammation yet. So there's going to be changes in the area itself. If it's closed, we get whiteheads, whereas if they're open, the comedones themselves actually become blacker. That's due to the actual sebum being oxidized. So that oxygen in the air is exposed to the sebum. That causes it to turn black when it's open. If it's moderate, we're getting towards that inflammatory side of things. So that's when we start getting actual papules and pustules forming. These can scar as well, which is something that we'll have to keep in mind when we're managing our acne. If it's really severe, these papules can grow in size and become nodules and cysts, which can be painful, widespread. We can also consider it to be severe if these lesions are a bit refractory to our management, or they've got a significant psychological impact. Okay, from a non-pharmacological standpoint, we're going to be washing our faces, but only once to twice daily. So excessive washing isn't going to be good. Also avoiding to squeeze spots, because that can just really drive the inflammation a bit deeper, cause a bit more scarring. We also want to avoid using too much makeup, remove prior to bed, washing our hair regularly, and then soap-free cleansers to just make sure that we're clearing the sebum that's in the area that could be blocked. In terms of what we can do from a pharmacological standpoint, starting off with mild, I know there's a lot on this page, but the general principles are, if it's comedonal, or rather, let me start off with this. There's kind of three main elements that we can try. Topical retinoids, so vitamin A analogs, topical benzoyl peroxide, or topical antibiotics. Now, most people will start off with an over-the-counter product, so BPO, salicylic acid, or niacinamide. But depending on the comedones themselves, and how much inflammation is going on, we can consider what we want to use. It's broken down there where if there's not as much inflammation, we can just do topical retinoid. If there is some inflammation, we can add BPO. If there's a mix of both, then instead of the BPO, we want to use antibiotics. Yeah. If it's moderate, the main thing is that we go from topical retinoid and BPO to adding on oral antibiotics, so doxycycline. We can also do this if the distribution extends to the back or the chest. In female patients that have moderate acne, we might look at the underlying cause, as it can be associated with hormonal changes. So we can switch them to if they're on an oral contraceptive, we can switch them to one that has an anti-androgenic progesterone, as that can be a risk factor for why they've got the acne itself. And spironolactone is also something that works quite nicely. If it's severe, we might be considering oral isotretinoin. This is something that a dermatologist will make the call on, not us, because there's a lot of side effects associated with it, and it's a long course, so needs very good compliance as well. Cool. Rosacea. This is a chronic inflammation now in the facial units. As a result, the capillaries become more reactive and we get flushing telangiectasias in the face. It's fairly common and it can be exacerbated by a lot of different things, often like heat, sunlight, alcohol, whatever. Clinically, we get an ace of clubs distribution of redness and flushing. It's fluctuant again, so it comes on, comes off, depending on what your exacerbating factors are as well. As it progresses, we might get persistence with this flushing and can also see pustules and papules depending on its severity. For older men as well, we might see rhinophyma, which is where the nose itself becomes a bit more bullous, and there can be some thickened skin over the area as well. Main management for rosacea is to avoid the triggers, SNAP W, sun protection, using gentle cleansers, and then from a pharmacological standpoint, some topical antibiotics. So starting off BD and then once daily. So metronidazole we can start with, but also Clinda, erythromycin, sort of depends. If it's a bit more severe, we can also consider some oral antibiotics. And then if we want to surgically manage it, there's a few different fun things that we can do, but that's going to be a derm decision to make. We can also see a variant of rosacea called perioral or periorbital dermatitis, which is where it can be idiopathic, but topical steroids can cause it. So I mentioned steroids can cause dermatitis. This is one example. We get erythema and papules in the affected areas. The main way to manage it is pretty straightforward. You cease the topical steroids. We're going to get a flare of whatever we were treating those steroids with. But ultimately, it's going to clear completely, and then it won't recur after doing so. Okay, I need another sip of water before we start talking about infections. Okay, so let's start off with our bacterial infections. There's only a few that we kind of need to know, and the management is not too bad. Erysipelas. We'll also talk about cellulitis. They're very closely related to one another. Erysipelas is a superficial infection. Realistically, it's only affecting the epidermal layer and the lymphatics, I guess. There's a few different risks there. So things like Fish's venous disease and diabetes, poor skin healing allows for exposures to the area itself. And 2/3 of the time, we get strep pyogenes, so our group A strep. And then 1/3 of the time, we can also get Staph aureus. With the features of erysipelas, we get a very sharp raised border. It might be a bit hard to actually appreciate here, but it's like pretty well demarcated. It's a bright red, firm, swollen, tender lesion. It can be warm to touch as well. And in terms of how we actually manage it, some of the things that are important to start off with are your basic analgesia, antipyretics, and then elevating the leg. I would also recommend to mark the border of the redness. You do this for cellulitis as well because sometimes it can be a bit hard to differentiate one from the other. So this helps reassure you that it's not cellulitis. Antibiotic wise, if there's systemic involvement, they need IV antibiotics, so they probably need to go to hospital. Whereas if it's non-systemic, then depending on what we suspect, we can use different things. So if they're not really at risk of MRSA, we can go with Fluclox 500 6 hourly. Or if we're suspecting strep pyogenes, then we can go with phenoxymethyl penicillin. Yeah. Cellulitis, on the other hand, is where this infection is going into our dermis and the subcut tissue. So affects mostly the lower limbs, often just going to be on the one side, and almost always it's going to be group A strep. The main difference is that the borders are hard to define, the erythema is hard to define, and that makes sense because we're in our dermal layer, so it's spreading out a lot more, whereas the epidermis, when that's affected, it's going to be a lot more localized and therefore well defined. It's not going to blanch when we put pressure on it. It'll be warm to touch, painful, swollen, and we can see some systemics as well. The management is effectively the same thing as how we manage erysipelas, though. But the reason why we're concerned here is that the complications are really nasty. So we get neck fast, gas gangrene, severe sepsis, and endocarditis. I've just got a quick point about neck fast. It's not technically something that you would see much in GP, but we get a really, really severe bacterial infection of a soft tissue area. Typically, we get some kind of infiltrating wound, and then we get thrombosis into the blood vessels. Pathogen-wise, can be various, or it can be just the one, but a few of the common ones that you would have heard about: strep pyogenes, Clostridium perfringens, and Staph aureus. Again, are poor wound healing risk factors. And then clinically, constant severe pain, as you can see visually as well. There's going to be some skin necrosis and bruising, so blackening of the actual skin itself. We can also potentially get gas in the soft tissue. So when you palpate it, you might feel crepitus, or it could be seen on imaging as well. Systemically, there might be febrile or have some deranged white cells or CRP. And then there's also this dishwasher sign, which is where when we go to actually incise the affected tissue, we get this gray fluid that kind of looks like dishwater leaking out. It's really bad smelling. And then, yeah, management wise, if you were to see this in GP, they would be shipped straight to hospital. They need an urgent surge referral, and this needs to be debrided, and we need some empirical antibiotics. So, depending on if there's water exposure or not, meropenem, vanc, and clinda add on the ciprofloxacin if we need it. And then once you've got your sensitivities and stuff back, then you can get a more specific regime. Okay, impetigo or impetigo, I don't know how to say it. Really, really contagious superficial infection, common in kids. It can be either primary, which is where the normal, healthy, intact skin gets infected, or it could be compromised skin, so something like eczema, as we talked about. 80% of the time, going to be Staph aureus, but we can see there's group A strep infections, especially with our indigenous patients. You can skin swab it, but I would say often you don't really need to. Location-wise, often going to be on the mouth, the face, and the hands. And we get this kind of honey crusted with this honey crusting with some surrounding erythema as well around there. Often can be quite itchy and irritating, but not really painful per se. It also can blister, so we get bullous impetigo. And then ulcerative, that's usually going to be with our strep pyogenes infections. Lifestyle-wise, again, similar to our eczema and stuff, A, B, C, D, E. So some things that are really important is that this patient can't go back to daycare until a day after starting the topical because we really don't want this to spread. It's very easy for it to. To remove the crust, we can do a warm compress, so some like warm fluid and just like a towel or whatever, to just wipe them off gently. And also really important to wash any other linen or clothes in hot water. For the site itself, depends how big it is, but if it's a small site, we can use mupirocin or Bactroban. Do that 8 hourly for about 5 days. Clean off the crust first and then apply it there, which kind of makes sense. If it's systemic, we can consider some oral flu clocks. And if they're at very, very high risk of strep pyogenes, we can consider a benzathine benzoyl penicillin one-off dose, IM. Okay. Furuncles or boils is where we get folliculitis, but it's kind of a bit deeper. Often going to be Staph aureus. I think the main things are we just get these tender red spots. They can be elevated to papules or pustules, and they're centered around a hair follicle. In terms of managing it specifically, we would want to do an antiseptic or an antibacterial soap about 1 to 2 times a week. Can consider a topical antibiotic as well, so mupirocin again. And if it's particularly bad and not really responding to the antibiotics, you may need to drain it. Okay, let's go on to viral infections now. So looking at HPV first, we get these abnormal growths in the skin mucosa, and HPV is our causing agent. Now, there's a lot of them to know, but 90% of the genital variants are going to be 6 and 11. It can be either person-to-person contact or from contaminated surfaces, and it can take up to a year for this wart to present from the actual exposure itself. It tends to disappear with increasing age. I think the main things to know are that these warts tend to actually resolve by themselves within a year or two. And if we're treating them, it's often if they're just quite troublesome or uncomfortable. And once we start a treatment, you have to make sure you keep doing it until the wart's completely gone. In terms of what we can do, I think the main things that I've seen are cryotherapy and salicylic acid, but you can also consider like occluding it with duct tape. Can consider excising it, but the rate of recurrence is higher. And then there's also some systemics we can consider. But yeah, generally for warts, I think cryotherapy is the mainstay. HSV, on the other hand, where we get painful ulcerations. Now, burning, itchy sensations can stratify into type 1 and type 2. So type 1's going to be in the mouth area, painful, often can affect their swallowing, and they can be a bit febrile, feverish, and they're often going to be like younger, so 1 to 5 years old. In type 2, this is genital herpes, where starting after the onset of sexual activity, we get these vesicles, redness, and swelling for about 2 to 3 weeks. And if they're recurrent, these vesicles tend to be a bit more like smaller, closely grouped, and we've got a few different triggers there as well. We can do a viral culture of the actual swab area itself for genital herpes. And yeah, depending on the type, so type 1 really is only going to be supportive therapy. Add on like your topical analgesia and consider the antivirals. But for type 2, so our genital herpes, we need to have some oral antivirals. And yeah, the oral antivirals are only going to be especially useful if they present within, say, like 3 days of the actual first presentation. Okay, molluscum contagiosum is pox virus, spread from skin to skin contact, or can be indirect as well. We get these kind of small dome papules, and they've got central dips, so they're umbilicated, you can see right there, and are going to be kind of skin colored. But at the end of the day, these just spontaneously resolve on their own, 6 to 9 months. Recommend that they only take showers. And if they really, really want to get treated, we can consider some liquid nitrogen or something to get rid of them. Pityriasis rosacea is where we get a lesion that looks kind of like this, called a Herald patch. single large patch, and then after which we get an eruption. So to start off with, there's a bit of a prodrome where for a couple of weeks they have like coryza, flu-like symptoms. Then they get this herald patch where we get a raised red border, and then the center is a bit more like salmony, whitish. And then this eruption after. You can see it's a bit hard to maybe appreciate, but we get a Christmas tree pattern, which is where along the back they kind of follow the skin tension line. So you can imagine that it's going out this way, almost like it's not really dermatomal, but you can see how like dermatomes go out that way. It's kind of like that. The good news is that we don't have to treat this. It's spontaneously resolving, so we can just reassure our patients if they have this happen. Okay, varicella zoster virus. We'll talk about chickenpox first and then shingles. So this is a very highly contagious virus spread by droplets. We see it most commonly in unvaccinated children. The vaccine in our schedule is at 18 months old. Once they have it, they technically are lifelong immune, but then it can reactivate as shingles, which kind of sucks. If we find that a patient has this, we need to notify the Department of Health. Incubation period of about 2 weeks with a prodrome of a couple of days prior to the rashes onset itself. So they get feverish, they get malaise, and then we just get a widespread rash. Red macules into papules into vesicles, and then the vesicles themselves erupt, crust over, and then we get some hyperpigmentation without scarring. Very, very, very itchy though. Cool, can have some other associated symptoms as well. Yeah. Here's some photos about the actual like course of it. So you can appreciate how as time goes on, we get an eruption and then crusting over that hyperpigmentation. And then ultimately it will resolve over a 15-day, not 15-day, like a couple of weeks. Great. In terms of what we need to do, these patients have to stay out of school. We obviously have to notify the department about it. They can only return once their lesions are crusted over or it's been over a week. Once lesions are crusted over, they can't actually like be transmitted. The varicella can't be transmitted. It's once the eruption happens, that's when it gets transmitted. For the itch itself, we can consider like a calamine lotion, cool compresses, and can consider some antihistamines orally as well. And then pharmacologically, you don't really use the antivirals unless they had this underlying like eczema or they're like a very young patient. We can consider the acyclovir as needed. Okay, shingles. This is where the varicella is latent and then it reactivates in the dorsal root ganglion. Older patients are going to get this, and it can be caused for various reasons, stresses, any pressure on the nerve roots themselves. You could wound swab it, but generally, if you see a dermatomal blistering rash with severe neuropathic pain, it's likely going to be shingles. So you can see here, we've got a very clear kind of, dermatomal distribution over here. How do we manage this? The main thing is going to be that we apply like protective ointments to help with the like pain and itch side of things. Again, calamine lotions, those side of things as well. Analgesia is really tough when it comes to shingles. So for the neuropathic pain, we can consider like an amitriptyline or a gabapentin or pregabalin. And if it's particularly bad, move on to pred for a course. These patients should get antivirals as well. So valacyclovir, famciclovir, acyclovir, whatever you feel like, I guess, within 3 days of the onset. And we've also got a Shingrix vaccine. So if they're older than 65 years old, they would be eligible for that. So highly recommend it to your patients because no one wants shingles. We also want to keep in mind this post-herpetic neuralgia, which is a bit more common with our facial infections, but it's really hard to treat. These patients need to be seen by a pain specialist um, to consider kind of more extensive pain management. Okay, quick point about some fungal infections now. So we'll start off with tinea, which is where our fingers, hairs, or nails are most commonly affected by this most often dermatophyte fungus. There's a lot of subtypes. I wouldn't get too hung up on that. In terms of the clinical features, we get a kind of circular eruption. The edge is irregular, and then the inside area is a bit clearer. There might be some swelling or pustules as well. Now, to investigate it, we could do a culture of the surface scrapings, but that just takes a long time to come back. So we might just consider starting them on topical antifungals or oral if it's very extensive, just to get the ball rolling. So we got here a few different variants of tinea, starting off with corporus, which is ringworm. I guess the main thing is that if it's chronic, you can see it often in the folds, get itchy, inflamed red patches. Jock itch is crurus, where it's going to be a raised erythematous border in the groin area itself. Tineipedia is very, very common. Often going to see it where it's between the digits of toes, in particular, athlete's foot. And it's often going to be, asymmetrical and can be unilateral, can be bilateral. Tinea unguium or onychomycosis is where the nail bed itself is affected and infected. So we get thickening, we'll get nail actually destruction going on, easy to break, common with older age. And then lastly, capitis, which is where the scalp's affected. We get this kind of hair loss picture in patches. We get broken hairs on the surface itself. And then there's a few other things that can happen with carrions, fungal abscesses, or fabius, which is yellow crossing and the hair is a bit matted. They can have some lymphadenopathy as well. Okay, so again, just to recap that the management itself, if it's localized, topical antifungal such as terbinafine or clotrimazole, but if it's a bit more extensive, we might do an oral instead. Okay, Psoriasis versicolor. This is where we get a superficial fungal infection of the corneum, Malassezia fungi again, and we see it in our young adult patients, often going to be on the trunk itself. We don't really need to actually treat it because it self-resolves in a couple of months. The main thing is that we get these like pigmentation changes. And if it's particularly concerning, we can do topical antifungal like shampoo or whatever, but not particularly necessary. Great. Okay, that's it for infections. Let's go to ulcers now very quickly. So I think the main thing when it comes to ulcers is knowing about how to differentiate them between the main causes. So the vast majority are going to be venous ulcers. That's probably to do with the risk factors associated with these ulcers. We can also have arterial pressure, neuropathic, vasculitis associated, or a mixed picture as well. Main risk factors are things that you'd expect with smoking, high blood pressure, obesity, diabetes, certain lifestyle factors as well. Now, when we describe our lesions, there's a lot of different things to keep in mind. I don't have a good mnemonic. I don't know. L, SAD, MIS, BGPs, S. Does that work? Anyway, so the location, where is it? Certain ulcers are going to have different sites that they are more common at. How big is the ulcer? What does it look like? How deep does it actually go? So can I see like muscle? Can I see bone even? Looking at the margins, do they kind of come inwards, so sloping? Looking at the tissue around, and then actually looking at the tissue itself. Is it healthy and healing? Is it slothy? Is there pain? And is it infected? So on this next slide is a table that pretty well summarizes all of the different things to expect with our ulcers. And I'll probably just go to the next one because this one is also good, but it's got photos. So looking at venous ulcers, to start off with, the main area is going to be the medial malleoli. And what you can notice with these is that they're going to be a bit slothier. So there's going to be yellow kind of granulating tissue on the inside of them. And then around it, you'll notice that there's this kind of staining. So it's a bit darker surrounding the actual ulcer itself. Um, I think those are the main things to look out for with your venous ulcers. Arterial, the buzzword here is like a punched out uh, ulcer. These are going to be a bit drier, so no real slough around the tissue. There's going to be like no hair. It's going to be shiny. Um, and instead of the medial malleoli, which is the venous one, these are going to be more on the lateral side. Um, can also be in the like, where is it? Oops, sorry. Go back. Um, these can often start kind of like distally, so looking at the toes as well for those ulcerating, arterial ulcers. Might also need to look at the pulses as well to look at are they present still or not. Neuropathic, as the name implies, is to do with the nerves and is often going to be in pressure areas. It's different to a pressure ulcer though. So neuropathic is more like as a result of a sensation loss. You don't notice that this ulcer is forming. So in our diabetic patients which have peripheral neuropathy, it's going to be those kind of pressure areas on the soles of their feet. So in the heel or in the toes or over the balls of their feet. Those are going to be the main things. They can be dry and a bit cracked, calloused as well. And then looking at pressure ulcers, these are going to be in areas of pressure. But the main thing is that they technically have sensation preserved. It's more that they have limited mobility, and so they're always in the same position. So if anyone's gone to like an aged care facility, they're very, very like not pedantic, but like very particular about making sure to prevent pressure ulcers. So this will involve moving the patient around to make sure that they're not in the same position all the time. Certain beds have like these like air pumps on their legs to keep them moving around so that they're not always just putting pressure on a kind of bony area like the heel of their foot or over the sacrum. Yeah. Here's some other photos about kind of the different ulcers that we've got as well. So again, arterial, you can kind of appreciate it's a bit more kind of punched out. This would be quite painful as well. The venous one over here is a bit more sloppier. There's a bit more going on the inside, and then we've got the staining around it. Pressure, again, over the sacrum itself. Neuropathic, this person's actually had an amputation. That's how bad this is. You can see that it's pretty remarkable. I think you can see like the musculature underneath as well there. And then a mixed one here, where even though there's some slough as well, the borders themselves look a little bit like kind of shiny. So there could be some arterial involvement in there as well. All right. From a management standpoint, it sort of depends what's going on. So if it's venous, we want to improve the venous return. So we can use compression stockings, leg elevation, and then there's some consideration for surgical management. Whereas if it's arterial, compression is not going to do as much because the arteries are what's affected. So we might try some revascularization, antiplatelets depending, or managing their risk factors as needed. Neuropathic and pressure, we need to make sure that there's not pressure on their actual areas that are affected. If they're diabetic and they've got neuropathy, we should manage that. Or if they have neuropathy for other reasons, like vitamin deficiencies, managing that appropriately. And then also encouraging mobility for these patients too. Okay, that's just a slide on wound care, just briefly. And then lastly, hair and nail conditions. These are very, very rare to see, so I won't spend too long on them. This is just a revision about hair growth, where majority of them are in this anagen growing phase. The division happens in the dermis, and then the follicles themselves have like 3 to 4 hairs, depending on where you're looking at them. Okay, androgenic alopecia is the most common balding, way more in men than in women. So for men often see it in their 40s, whereas with women, it can be a bit later on in life. They get thinner hair and they get less hair per follicle, called miniaturization of follicles. And the distribution sort of depends, but for men, you get bitemporal recession. You can kind of just imagine like a balding person, and that's probably the distribution. For women, it's a bit more diffuse. Clinically, you diagnose it. There's no real definitive management. We just slow the progression. So there's a few different options for what we can do to help reduce this progression, or we can do more cosmetic things like camouflage or transplants. Alopecia areata is the autoimmune alopecia, where we get non-scarring hair loss in kind of patches. You can see how it's almost a bit similar to the tinea capitis. But the reason, we also get some other things. So hair's getting broken off. We get exclamation mark sign, which I don't know if it's easy to appreciate, but we get broken tips at the end. So it kind of looks like if you drew an exclamation mark. And then to investigate it, we do the hair pull test. So that tells us whether the actual hair follicles themselves are being attacked. We can also screen for other autoimmune things. And this usually remits on its own, but we can consider treating it if we want to slow the progression. Trichotillomania is actually a psychiatric disorder where we get a compulsion to pull out one's own hair, and that causes alopecia. The main thing to differentiate it from alopecia areata is that the negative hair pull test. So is that the hair pull test is negative. In terms of managing it, it's more from a psychiatric standpoint. So behavioral therapy. In our younger patients, we might need to try things like gloves to cover the hands to prevent the actual pulling from happening. Okay, and we've got a couple of slides on nail disorders, some of the terminologies. I wouldn't worry too much. I think the main ones are like what's ridging, you get horizontal lines, what's koilonychia, you get the spoon shape, clubbing, and then over here like splinter hemorrhages, leukonychia, onycholysis. Just know what the terms mean. I wouldn't worry about memorizing this. Onychomycosis is where the nail is infected with a fungus. So we've already kind of touched on it briefly. Most of the time, these are going to be dermatophytes. In terms of how we manage this, keep the area cool, dry, treating anything that's been infected. And then we can do a topical antifungal if it's in the distal third. If it's a bit more, we can consider an oral antifungal, or we've got some alternatives here. Okay, that's it for dermatology. I know that there was probably a lot in this PowerPoint itself. So yeah, in terms of advice when it comes to dermatology, again, a lot of it is like pattern recognition of what does this lesion kind of look like. Look at the clinical scenario of how has it changed. So for our melanomas or other cancers. And then from your from your general dermatological management, if you're stuck, try to break it down into lifestyle. Okay, next, what topical options do I have? Okay, next, is there anything else a bit stronger? Like oral therapies, UV, that side of things as well. But good luck, everyone. Hopefully you guys are feeling okay for where you're at the moment. If you have any questions, you can just shoot me an email or a message. I'm fairly responsive. But otherwise, best of luck, and hopefully I'll catch some of you at the revision day coming up. Good luck.